Hello, everyone, and thank you for attending today's Clinical Labs Blood and Microbiology Digital Forum event. My name is Mary Beth Donna, and I'll be moderating this discussion. The needs of today's clinical labs are rapidly changing, presenting a challenge to keep up with the latest information and techniques. Today's Clinical Labs virtual symposium will help fill that need with in-depth digital presentations from key clinical thought leaders. Welcome to this session, Emerging Pathogens Update, Pathology, Transmission, Treatment, and Prevention. The National Institute of Allergy and Infectious Diseases defines emerging infectious diseases and pathogens as those that have newly appeared in a population or have existed but are rapidly increasing in incidence or geographic range. The 21st century has seen a concerning number of old foes and novel microbial agents emerge or reemerge globally. Please send us your questions or comments at any point during this presentation by typing your query into the Q&A box on the right-hand side of your screen. Our speaker will address as many of your questions as possible during the time allotted. Please see the Handouts tab on the right-hand side of your screen for supporting information about this event. I'd like to remind you that the recording of this webinar will be available for free on-demand viewing after the conclusion of this event. And I'd like to extend a special thank you to our sponsor, the Joint Commission. Their support allows today's Clinical Lab to offer these webinars free of charge to our readers. So with that, I'd like to introduce our speaker for this presentation. Rodney E. Rohde, PhD, is University Distinguished Regents Professor and Chair of the Medical Laboratory Science Program in the College of Health Professions at Texas State University, where he also serves as the Associate Director of the Translational Health Research Center. Rodney, thanks for joining us.
Thank you so much. And hi, everybody. It is a pleasure and an honor to join today's Clinical Lab. I also like to throw a shout out to the Joint Commission. Always appreciate the support for these types of really critically important information for our medical laboratory, public health, and other laboratory professionals out there. So as mentioned, this is going to be my topic today. It is one that is very near and dear to my heart. I have worked in this area in zoonotic disease, within the public health world, within the medical laboratory world, for a little over 30 years now. So the beginning of my career was with the Department of Health in Austin, where I worked in Zoonosis Control Division and in the laboratories as a public health microbiologist, and just had a wonderful time doing that for about a decade. I also did a couple of stints at CDC as a visiting scientist, and then transitioned into academia in the medical laboratory world in 2002. So I have one foot firmly planted in public health and epidemiology, and one foot firmly planted in the medical lab healthcare world. And it's really served me well over the course of my career with respect to infectious disease and outbreaks and responding to said outbreaks. I've been through several rounds of these over my 3 decades now. This slide just is always a good starting point for me. I've used this during the COVID pandemic. I've used it prior, and this goes back many years, but it really always grounds me as a public health, a former public health professional that worked in the trenches of rabies and plague and hantavirus and flu and West Nile virus and Zika and all the other things that have come through over the years. But this is the world we live in. And I always have to remind my students and my colleagues when the public or government or other people get, a little cranky about response times and what we're doing during a pandemic or even a really big outbreak, everything we do before an outbreak or a pandemic often seems alarmist. In other words, we're spending too much money, we're taking too much time planning, we're doing too many bench level kind of practice scenarios for outbreaks. And so that's always there. But if we don't, then everything we do will seem inadequate. So we're kind of caught in the middle in public health and healthcare, and that just goes with the job. But it always brings me home when I think about that. And I want to give you all encouragement who have worked in the trenches over the past 3 or 4 years, and even during your career, because it's sometimes a thankless task. But we all know how critical you are as the heartbeat of healthcare and public health. So thank you for all of your work. This was just kind of introduced to you, but I'll just throw it up here for a second and add that, the 21st century has really seen, what I would call a high level of emerging and re-emerging agents. Many of these I'll talk about today. I'm going to focus on several up front because I think they're right dead center of our life right now. But I am going to look out to some others that are popping up, like Nipah virus and Marburg, some antimicrobial resistant issues, and so forth. So that's going to be the focus of my talk as I walk through it. And you will see just from the learning objectives that I'm going to focus a little bit on the microbiological area. Can't help myself, right? I'm a trained microbiologist, so that's part of what I'll be doing, but also get into the pathology a bit, some of the transmission issues, prevention and treatment. Are there vaccines? Are there vaccines on the horizon? Are there issues with antivirals or antibiotics? And then ultimately, and I actually do this up front, I'm going to talk a little bit about the global and local factors that have contributed to this issue. Some of these you probably are well aware of, but I want to set the stage, the foundation for our talk by discussing that. So historically, and I'm a fan of history with respect to these types of things, infectious disease outbreaks have certainly shaped our culture, our society, our very well-being throughout human history. And so when you look over history and you think about things like Black Death, the bubonic plague, or yellow fever, which is unfortunately making a bit of a comeback, even influenza, typhus, all of these things have really hampered and afflicted humanity over many, many centuries, sometimes actually determining the outcome of wars, wiping out, empires, wiping out governments, and even populations. So certainly, I always talk about infectious agents have no bias. They have no prejudice. Just like SARS-CoV-2, it really didn't matter where you stood from the standpoint of your political persuasion or your socioeconomic factors or anything else. The virus just is going to virus, right? I mean, all they want to do is infect, amplify, and transmit. And that's really still true. If you go back to the 60s and 70s and the 20th century, we really, and this is right as I was coming to being on this earth, public health was really shifting away from acute infectious diseases to more chronic illnesses, because we really believed that antibiotics and antivirals and vaccines had really helped us, if not defeated, had certainly put them in their place, right? And that was kind of a widespread thought at the time. We certainly know that's not true. In fact, if you look back, I threw this in here for just interest if you didn't know this. If you go all the way back to the time of the American Revolutionary War against England, George Washington, the father of our country, actually implemented a smallpox inoculation mandate in Pennsylvania. And really any troops that were coming through Philadelphia were required to be inoculated against smallpox in the winter of 76 and 1776. Back then, if you know your history, that was done through the process of something called variolation versus injection, which came later with Jenner. But because of that simple policy that he implemented, all but about 50 of Washington's troops survived smallpox outbreak in that area and survived the winter of Valley Forge. Really helped shift the dynamics of the war in favor of the Continental Army. In contrast, if you remember a gentleman named Benedict Arnold, he forbid smallpox inoculation in his troops, and they were in Quebec. And illness, death, and defection due to fear of smallpox basically forced him to retreat. And it's really considered one of the main reasons that we don't control Quebec and parts of Canada as well. Overall, what Washington did reduced the mortality of smallpox to about 2% or less in our Continental Army, and it was 30% or more mortality in Benedict Arnold's army. So just a little bit of history there with respect to public health. I'm a firm believer in public health. I really believe the U.S. and our country was founded somewhat on the duty to uphold public health, and so I'm a very big supporter of that in many ways, and it really does help protect the populace. After, as we move through the 20th century, and some of you remember this, we started having subsequent epidemics and pandemics, and probably HIV was the wake-up call that really helped kind of knock that belief down that we were kind of free, or at least had controlled infectious diseases. And it really helped us start understanding that this was an ongoing evolutionary issue with respect to microbes. However, right? Even though HIV really hit us, I was in high school in the 80s when this was kind of really rolling through. We still seem to have some issues where we didn't learn some lessons. And so history has unfortunately repeated itself, especially when you think about the most current issues of SARS-CoV-2, and you might even throw in the global emergency of monkeypox or mpox with respect to ongoing global impact of these types of events. So EIDs, just so you know, if you see these acronyms, are emerging infectious diseases, okay? And our EIDs are reemerging infectious diseases. They really are responsible for a really large proportion of most outbreaks now. Typically, they have a zoonotic origin. I'll talk a little bit more about that in a moment. Near and dear to my heart, these types of infections really are emerging from an animal species. It can be wildlife or domestic or even domestic pets, and it crosses that barrier into humans. So that's kind of the definition of a zoonosis. It typically occurs through animals to humans through direct contact. So think about a bite or a scratch or something like that. But it could also be through droplet fomites or water, food, or other types of vectors like a mosquito or a tick or so forth, or even surfaces, depending on what the situation is. This is just a quick slide here that the CDC puts out, kind of emphasizing that. So I wanted to throw this slide in here to remind people that animal health is absolutely important to the prevention of issues in human health. And I would even add here on this slide that the other focus needs to be on the environment. So I'll often talk about this in my presentations or in my writing, that animal health plus environmental health plus human health equals a One Health initiative. And if you know anything about CDC and the WHO, the last few years, we've really tried to focus on a One Health lens of viewing infectious diseases, in some instances, even chronic illness, so that you're not siloing any particular area. You know, you have to think about animal health. You have to think about water and climate and forest and deforestation and travel, and all of these things can impact how germs spread between animals and people, or people to animals, vice versa, or from the environment into either one, whether it's direct contact, whether it's indirect contact, whether we're dealing with vectors. There's a lot of vector-borne things. I'll talk a little bit about that in a moment. We have malaria popping up in the US again, or foodborne, right? So all of these things are really critical. And that is a key point that I want you to think about as you leave this webinar today, is how that interplay between animal health and humans and vectors and environmental aspects are all tied together. It's kind of a no-brainer, but it's something that we always have to think about and be purposeful when we're thinking about prevention or treatment, or how we treat Mother Nature, right? It's really important to think about these things. So not all emerging infectious diseases or reemerging infectious diseases come from an animal origin. There are others, as you were aware of, that are very much related to other things, right? So things like multi-drug resistant organisms, like VRSA, vancomycin resistant Staph aureus, or a more kind of current thing we're dealing with, Candida auris. These and others are typically considered non-zoonotic. They're more related to antibiotic or antimicrobial resistance, either overuse or misuse or both. You probably are aware that this is a very big global ongoing emergency. I've often referred to AMR as a slow burning pandemic that's been around way before COVID. It's probably been most noticed in the last decade, but even the last 2 decades, we've been dealing with many antimicrobial resistance issues, and COVID actually helped exacerbate those issues because we lost some ground. And so we'll talk a little bit about that. Regardless of the origin, a pathogen to be established in the community, it typically needs to be introduced into a vulnerable population. That's one big factor. And then have the ability to spread human to human. And then keep that animal reservoir in mind, or other reservoirs, insects and things like that. Because if you can't vaccinate the entire human population, or even if you do, with respect to SARS or anything else, rabies or anything else, that disease, that agent's going to remain in the animal population or in an insect population. So you're not going to be able to eliminate it completely unless you find ways to do that. And that's very, very difficult. The last time we did that was smallpox. The other thing to keep in mind in this historical context is that huge developments in technology and GIS and the internet and all of these other types of things have been very important with respect to surveillance and diagnostics. That has led to the realization that EIDs and reemergence has really increased over the last few decades. You can feel that, right? You can kind of tell that. But that improved detection of outbreaks in general really helped facilitate early implementation of response measures. So we do have the good news that many times now we have the ability to respond in a much quicker and effective way. Even though we learned some hard lessons with COVID, there were some really miraculous things that happened to get that control, that vaccination rolled out earlier. Even after you control for the reporting effect, so that statistical reporting effect, most research statistical modeling designs do tell us that the number of EID events worldwide shows a highly significant relationship with time. So think about Ebola over the last decade or so, the ongoing issues with influenza, COVID-19, Mpox, all of these things continue to pop up. And so we are seeing a true increase in those areas. And then the data also shows, when you look at most research models, that in this outright epidemiology of what's going on, places like Asia, tropical Africa, and Latin America are really more likely. So the risk is higher in those areas for EID and REID events. But, and you guys know this, due to travel, due to geographic distribution changing with vectors and reservoirs, we certainly now see certain pathogens being introduced into new regions way easier these days, like especially with vector-borne stuff like dengue, West Nile, malaria, and so forth. So that's going to, I think, be an ongoing occurrence just due to travel, due to technology advances. Here are some of the factors. And again, this is kind of that global, local correlation objective that I was talking about. A great slide here shared here. This is from a NIH publication. The link is down there at the bottom, showing you that the emergence and reemergence of these disease agents really are tightly linked with human activity. It's really linked to us as well. And so you think about just the expectancy, the life expectancy. My grandmother lived to be 100 years old. People are living longer. You have better drugs to keep people alive longer. You have more surgeries. You have more opportunity to do things that you couldn't do 50 years ago or 100 years ago. That also opens up, a more immunocompromised population, which is a niche for infections, right? Urbanization, globalization, weather-related issues, migration, war and poverty, and people rapidly crossing borders. All of these things, AMR, antimicrobial resistance, all of these play a factor always, and they're all interplayed and they're amplified. Many times they're synergistic in many ways that are really difficult to deal with, right? I mean, this is a big problem. I don't know if we'll ever stop the emergence or reemergence of infectious diseases, but there's certainly some things to learn and watch and get better at with respect to how we handle some of these human factors that might help us at least reduce and slow down some of these issues with pathogens. Okay, so this is a transition slide. So I'm going to start looking at some current issues. I thought I would start with the old fungus Amongus that's been on everybody's mind over the really past several months. But Candida is not a totally new to us. We've often known about other Candida species that have caused typical yeast infections and so forth. So this is one that we've dealt with. It's just that it's made its way back into a more kind of tough area because of resistance issues. This particular species, if you didn't know, was first detected in the ear canal, the external ear canal of a 70-year-old Japanese woman. That was really when it was first detected several decades ago. It didn't really emerge until recently as far as being kind of an antimicrobial resistance issue. It can spread patient to patient. It's become an issue in healthcare and as well as the community. Sometimes you carry this bug as a colonizer on your body, even if you're not getting sick. And so when you have hospital or nursing patients become colonized, then you have that opportunity for transmission, not just to another person, but also to the environment, right? So it can show up medical devices or in the environment, in the hospital room or a community room. And it basically gives it an opportunity to be transmitted. It's got some other issues, right? So C. auris can be misidentified as other yeastin species when you use conventional phenotypic or biochemical methods. There's some different thermal tolerance properties, growth temperature properties. Some of you are familiar with Chromager. There's actually a Chromager Plus, Candida Plus, that helps you to sometimes to differentiate C. auris from other Candida species, but you can have misidentification. And the reason I bring this up, it's come up with Burkholderei. It's come up with some other kind of oddball environmental pathogens that get into human infections or immunocompromised states. And you can see the problem there. If you get the wrong bug, if you identify the wrong bug, then you get the wrong treatment plan, potentially. So you might be treating with the wrong antifungal, or you might be treating with the wrong antibiotic for something else. That leads to AMR. And so it's really critical to get it right. And sometimes, we do the best we can, but there can be some problems there with certain bugs. API strips, Vitex, some of these other identification schemes with microscan can be used, but they often lack a big comprehensive database. Again, this bleeds into other bugs like Burkholderei. Maldy Toff, everybody loves it. It's kind of cool. I like to check it out myself. That does have the potential to quickly identify C. auris. We still need to watch that data come through with Maldy Toff. And then there's molecular-based tests, right? So you have PCR testing and sequencing, where you might want to get the genotype, for example, to figure out which particular thing is circulating. But it really has become a drug-resistant germ that we're seeing in the hospitals. There are definite increases, and I'll show you some of that data in a second. But it can cause really serious bloodstream infections. Even mortality can arise. You can see that little quote there, more than 1 in 3 patients with invasive C. auris infection usually dies if it's messing with the blood, the heart, or the brain. Kind of makes sense. The resistance, I'll talk a little bit more about that later, but some species of auris are showing complete resistance to all 3 classes of antifungal drugs. That's scary. And it's becoming more common. Okay, so I'll show you some of that data. So it began spreading, we think, in the US, where we really started detecting it around 2015. And they increased about 318% in 2018 when compared to kind of the average number of cases. This is coming through CDC's data. There were 323 clinical cases in 2018. About 80% of them were resistant to at least 1 antifungal. About 30% were resistant to at least 2 antifungals, and under 10% were difficult to treat at all. So you can see the immediate rise in concern. Again, this really kind of emerged out of Asia, we believe, and quickly moved around the world to become our problem as well. That this is true now, right? It's everybody's problem. Here is a look at a global threat. This is from CDC's data. If you aren't familiar with the antibiotic resistance threat reports, that's a great resource to check out. They're updating it every year or 2 now because it's changing so quickly. But you can see how these strains are global. And so they bounce around. They've showed up in the US, whether it's the African strain, the South American strain, the South Asian strain, the East Asian strain. Again, the beauty of genotyping and sequencing is that you can kind of keep a track on this movement globally. And this has certainly become a global threat as we move through the current year. If you look nationally at Candida, you can see here that we have this is through December 31st of 22. So again, this kind of block of time within CDC typically goes annual. And so 23 data is not really completed yet. But in those months of that year, you can see about 2,377 clinical cases, almost 6,000 popping up as screening cases. And the darker the color, the hotter the map. This is a heat map, pretty typical, a snapshot of looking at US infections. So California, Nevada, Texas, Illinois, New York, and Florida are showing 500 or more cases a year. The other states are somewhere less than that, but certainly it doesn't mean it's not in your state. If you're in a gray state, perhaps the detection is just not happening there for whatever reason, right? So it's probably more widespread than this when you think about what's happening nationwide. What should you do if C. auris is confirmed? So this is kind of guidance sometimes for hospitals and clinicians. You certainly should report it to your infection prevention and control department to kind of start following your processes. It's very much recommended that you conduct antifungal susceptibility testing. And if you can't, certainly finding help to get that done. And then start looking through cases, looking through surveillance data, maybe checking the environment, maybe checking other patients that were unknown infections and things like that so that you can get a handle on it. And then the right side of this is a fact sheet, again, from CDC. These are great resources. You really want to correctly identify it, and you also want to correctly figure out the antifungal MIC that are available. So there's a couple of resources for you to kind of dig into that. There are some I've seen recently, more and more webinars and more updates on expertise in antifungal susceptibility testing as well as identification. So you might keep your eye open, whether it's today's clinical lab or other resources that may be showing those types of specific webinars to kind of dig in if you think you have a C. auris problem. That reporting becomes really important nationally and statewide so we can kind of keep an eye on it. So good old coronaviruses. I sometimes wonder if the world even knew what they were prior to 2019. Some of us, of course, have known about them, thinking back to the first round of SARS or MERS prior to SARS-CoV-2. This just shows you a quick map if you're not familiar with the viral order, family, subfamily, and genus of this particular group. Notice that there's a couple of alpha coronaviruses, and then there's really 4 normal coronaviruses. Those are in the black. 2 of the normals are alpha, 2 of them are beta coronaviruses, and these 3 in red, which you may be familiar with, are the novel coronaviruses that we dealt with really over about the last 20 years now, because 2003 was the first hit with this. So it's hard to believe, but we have had other issues of this. And you can see a little of that history in a second when I show you. Just a quick reminder, again, we've been beat to death with this, and most people have seen this even in the general public. But this is an RNA virus, which creates part of the problem, much like influenza. RNA viruses are rapid mutators. They're almost diabolical in their ability to mutate and to be recombined and so forth. It is a lipid, a bilayer virus, so soaps and other types of detergents can disrupt that viral activity. Corona is known for their spikes, right? So if you look at it in an electron microscope, you see these kind of lollipop spikes sticking out of that particular nucleocapsid. That S spike attaches to human cell receptors. both in the upper and lower airways. And you might remember learning early on that they really target the ACE2 receptor, which is really found on almost all cells. So again, this is a global statement. It's got some nuances, but one of the diabolical issues with SARS-CoV-2 is that it can basically target and enter almost any cell in the human body because we have ACE2 receptors on almost all cells in our body. So, early on, you might remember, like, what's going on? We're seeing this in the kidney. We're seeing this in the heart. We're seeing this in different places in the body. So even though it was a respiratory virus, it manifested in many different ways. Really diabolical. Some information again about, there is a difference between upper and lower respiratory infections generally. Normally, human coronaviruses cause about 5 to 10% of common colds. Outbreaks can be up to 30%. There's the particular types of alpha and beta that we've talked about. About 4 of them really cause many common colds. They attach mainly to upper receptors in our cells. They're typically winter, right? But they can pop up in different areas. And it's the usual stuff: croupy, dry cough, rarely pneumonia, some diarrhea in infants and things like that. And then don't forget, in the world of respiratory viruses, there's so many others. Rhinoviruses, really, really common cold issues. A and B flu, adenovirus, parainfluenza, which is a big croup agent. RSV, we've got some new data now with vaccines happening. Even human metapneumovirus is an issue. So, and there's others. So there's a lot of respiratory agents to think about. We also have, when you start looking at these novel coronaviruses, that predominate in the lower respiratory tract, you really start thinking about SARS, MERS, and the current version of SARS-CoV-2. But I'm also going to put there in gray, and I just, threw out several of these that cause LRIs. These tend to be more problematic and sometimes dangerous because they're lower respiratory. Viral, you got, again, flu and adeno and so forth. Bacteria now, strep pneumoniae, the pneumococcus, Haemophilus, other things like staph can cause it. And then you got those nasty atypical community-acquired pneumonia, pertussis, mycoplasma pneumoniae, chlamydia pneumoniae. So there are differentials to think about there. And then if you look at the history, a really quick history, because I don't want to spend all our time talking about coronavirus today, but back in 02 and 03, we had the first round of SARS. The CFR there, the rate of that was about 10%, 50% mortality in the older population. It was more lower than that when you look at all age groups. MERS in 2012-13, about 10 years after that. This one's not contained. It still pops up. This was about a 35% CFR, really linked to camel exposure. There was also a lot of healthcare worker infection, kind of like during SARS as well. Aerosolization with intubation and nebulizers and so forth. And then SARS, of course, and this is, still ongoing. So we're not going to put an end date on it yet, but it's certainly winding down, we think, although we're seeing a spike right now with the latest variant. So we're going to say it's not contained still. It's variable, that ratio. It's as low as less than 1% in some countries, and it goes up to 4 and 5% in others. That rate of, and that all those rates, that mortality is still being determined. I still like using Johns Hopkins data. They were one of the first that tracked this pandemic. So there's a link there for you if you're interested in mortality around coronaviruses. Again, just some history to remind you, early on, all I was talking about when I was being consulted or asked for advice was about surfaces. I can't tell you how many conversations and articles and things I did around mail or grocery shopping or, touching things. And in hindsight, we now know that that was a less likely problem. It really was about aerosolization and not only short range, but even long range airborne transmission, because we were seeing these, these super spreader events, you might remember, in choirs and church and concerts and things like that. So, infecting dozens and dozens of people within kind of a closed, maybe not a very good area that had good air turnover and things like that. So we really learned and tried to adapt during the pandemic to those needs. Higher air turnover is really important. They started doing that in airplanes and things like that. Just thought I'd let you take a peek at these. I'm not going to dig through all this data, but just to look back. So this is, this really started probably in October, November of 19, but this shows you some data from CDC from January 2020 to January 23. Well over 100 million cases at this point. You can see the kind of classic curve of cases here. Blew up in January of 22. That was Omicron, but certainly we had blow-ups along the way, those different waves, if you will. The next slide looks at deaths. Again, the same time period, about a 3-year period. We're really at about 1.1 million deaths now in the U.S. that we know of. This definitely shows you that classic epi curve of the different waves from that first introduction to the different waves that kind of came through. You might remember the summer wave we had, and Omicron wave and Delta wave, and some of the different waves that came through. And really right up to now, if you look now, it's still kind of flat, but we are seeing a little bit of a peak, small peak, because we're seeing some new variant issues with coverage for immunity. And I posted this not long ago. I just threw this up here to kind of, a little bit different than 3 years ago. So this post was this summer, like July of 23. So really, at this point, we saw the lowest hospitalization and death rates in the U.S. since the start of the pandemic. It was about 5% of the peak. And we're hoping that continues to go down. We are now in August starting to see just a little bit of an uptick. If you're interested in that, here is something I grabbed literally this morning to share with you. Again, this is CDC's data tracker. So you can see from July 11th to August 12th of this summer, we have seen a little bit of an uptick, a plus 21% uptick in cases, hospital admissions, a little bit of an uptick in deaths, plus 8.3% in that time frame. And then you can see, we think, roughly we think our vaccination coverage is over 150 million. So half the population, we need more, coverage of that. There's recommendations right now for some of that type of activity. And I'll show you those in a minute. Just a question. I thought I'd throw this case up here in case you're curious. So, if you have COVID, a patient has COVID-19-like symptoms for 3 days and tests negative on a home-based antigen test, does the patient need any further follow-up, or is it safe to say they are not infected with SARS-CoV-2? So that's the scenario. And the answer says that the patient really needs further follow-up if they have those symptoms. They should probably seek a nucleic acid test or do a couple of times more with a home-based test, because typically there is a variable positivity reaction with a home-based test before you can really say you're not infected with SARS. Now, certainly it could be something else, but it's nice to kind of rule out SARS, especially if you're around immunocompromised individuals. Reminders of the types of tests that are out there. Again, generally the rule of thumb is nucleic acid amplification test are more accurate, and the rapid antigen test are more widespread for screening. Certainly more rapid to get that answer quickly, but ultimately you might need a molecular test to not only be accurate, but to perhaps identify the variant if the hospital or your physician wants to know that. Just some more, you really should check out CDC as well. They do have some great algorithms. They've gotten better over the last year or so. So if you've not had COVID or had a positive test within the past 19 days, then you can choose whatever you want if you think you're having issues. If you test positive for COVID-19 in the last 3 months, depending on what you're doing there, you can kind of see the breakdown there. Your first positive test was within 30 days or greater. Depending on where you sit, then you might want to pick different tests. There are some problems with molecular tests if you've been recently positive and cleared. Sometimes, this happened to me actually, sometimes you will show a positive molecular test because there are defective viral mRNA particles still kind of in your system, and that amplification of molecular testing can show you positive when you're actually not showing symptoms and you're basically negative at that time. That's when a less powerful technique like a rapid test may be better to predict your state. Update on antivirals. You might remember some of these over the course of the last 3 years. Some have become really less effective now due to the virus changing. Others are still working. Again, you really want to consult with your physician. Paxlovid's kind of the last one. It's a protease inhibitor. Sometimes that's useful if you get it within the right time frame. It can really reduce symptoms. Sometimes it's not going to be as problematic if you're not having problems with the virus. It's really a case-by-case type of determination by a physician. This is as of June 7th. There might be some very current updates coming in the next week or two with respect to boosters. So certainly those are available. And again, they're really pushing this for, immunocompromised, but really anyone 6 years or older, they're talking about getting that booster, getting up to date as we come into the fall respiratory season. Otherwise, again, talk with your physician, talk with your healthcare provider. There may be a reason for you not to do it, but generally it's a good idea. And this is what's happening right now. Again, I grabbed this yesterday, was doing a little bit of research. So EG5 is really the latest coronavirus variant. It's about 21% responsible for most cases that are circulating. It's a little different. It is a descendant of Omicron, which showed up back in November of 21. But many researchers and those that are following circulation basically believe the original version of Omicron is not circulating anymore. They're not detecting that. They're also not seeing Alpha and Delta, which was early on, you might remember. So we're thinking there's going to be much better protection this year with a new COVID-19 booster. There's also brand new RSV, respiratory syncytial virus vaccines for pregnant women and people over 60. Some monoclonal antibodies also for those. So RSV, flu, COVID-19, there are ways to better protect yourself going into this fall respiratory season. I'm actually putting together a respiratory webinar right now to do in the next month or two for some other resources. Good old Mpox, right when we thought things were calming down in the summer of 22, you might remember Mpox popped up. Certainly, WHO declared it a global emergency in July. We followed in the US in August, and we were off and running. It has basically ended as of January 31st, 2023, the actual emergency declaration, but we are still watching it, obviously, globally. There's a few, issues around this. So I'll pop through Mpox a little bit for time's sake here. It is an orthopox virus, which is where you find smallpox, vaccinia, and cowpox. It's not related to chickenpox. There are two primary clades of the virus. Fortunately, the one we've been dealing with is the lower case fatality rate, that's CFR. The Central Africa clade is higher, around 1 in 10 can die from it. And it was really first discovered back in the late 50s in research monkeys in Denmark. There's a whole story behind that. The reservoir is not completely understood, but we're pretty sure African rodents and non-human primates harbor the virus and infect people. The first human really happened in 1970 in the DRC of Africa. Historically, it's been limited to Central and Western Africa. And really prior to this 2022 global emergency, almost all cases were travel-based when they showed up in the US. That was not the case in this time. Previously, we saw it in 2003. I actually was working in public health more often back then when we detected this in African rodents. They were brought in to a facility in the US and they got in contact with infected pet prairie dogs and humans got involved. This came from prairie dogs that had been housed near imported small mammals from Ghana. And it was really the first time we saw that outside of Africa. 21, we saw residents from Texas and Maryland. Those were travel cases. Israel, we had a case. The UK in late 18 and 22, and then Singapore. So they do bounce around occasionally. This is the primary transmission route, right? So you got these are what we think are primary hosts. Then you've got bushmeat activity going on with hunting and eating and handling. And then you do have human-to-human transmission once it gets into the human population. This is a hard map to see, but this is CDC. This is relatively current. It shows you that a lot of the cases are global now, and really the predominant numbers of cases are in countries that had never experienced it before, including the United States. That map looks much better on a different format. This is looking at the US. So there's about, again, it's not totally up to date. It's within about a month, about 30,000 cases. There's 43 deaths now in the United States. This is a heat map. You can see where most of the cases have been reported with the darker colors. We are still seeing cases. Age-wise, it's typically in the mid-30s, but the range is all over the place. Again, globally, about a month ago, 148 total deaths. And so a lot of places, 22 locations with deaths. So it's really a global event. When you think about testing, again, for Mpox, remember it is a virus. If you haven't heard of the Laboratory Response Network, this has been around a long time. These are primary labs. Typically, the major state health lab is the LRN, and they get tests from the CDC. And so we had tests this time. This was really important, right? So we were able to perform a general orthopox testing, so you know that that DNA is present, usually using rash lesions. And at that point, you know that you have orthopox virus. You're not sure it's Mpox. And so then you do confirmatory testing by a real-time PCR. It's actually not just at CDC. This was early on. Now some state labs can do this. And I want to point out here with the asterisk, one of the big lessons we learned from COVID is we have to get these things shifted to large commercial labs quickly. So immediately with Mpox, they moved these into, I think, 4 or 5 of the big labs, even Sonic Reference Labs, which is here in Austin, Quest, LabCorp. Some of these labs came on board quickly, and this really helped us understand the virus transmission and spread around the country. A really good lesson, I think, that came from COVID, and that helped us to respond way quicker. Luckily, fortunately, with this particular virus, we had treatments available because many of these were used to treat smallpox disease. So TPOXX can be oral or IV, and it can be done on an outpatient basis. CDC had that in their strategic national stockpile, so we were able to start that right away. We also had kind of an algorithm to think about this when it was severe or high risk and so forth. There are major secondary complications with this. Remember, some of this was primarily through sexual transmission. They're still looking at that if it's a true STI, but it certainly was high risk, primarily with men who have sex with men. And so there were some other complications, including some issues around the genital area or other anatomical regions, or cellulitis or prostate involvement. And so there were some other complications to kind of keep in mind with using TPOXX. And then we were also very fortunate to have vaccinations on hand. So Genos and ACAM 2000 were both available. Typically, we don't use pre-exposure prophylaxis unless you are working in a research or other type of situation where you're exposed to it a lot in a laboratory setting. It can be used post-exposure. It kind of depends on a determination of when you may have been exposed to the disease, if it's going to be very helpful or not, or it might help reduce the severity of it. So there are different scenarios there for physicians to consider with Mpox. Okay, all good news, right? so all of this stuff is brewing, right? It's still going on. And then I thought I would throw in here the last few minutes, just other things that are popping up in the headlines, right? So, I could do a 3 or 4 hour conversation on all of the different things that are happening globally. These are some of the things that I have written about. I'm very fortunate and blessed to be a contributing author for ASM. I write for The Conversation, for infectioncontrol.tips, Elsevier, and some other types of articles and commentaries. And so Nipah virus, right? So this has popped up in the last year or so. This is transmitted primarily by flying foxes. Again, it's been primarily in other parts of the world, but something to kind of think about. This is one that I recently have talked about, ringworm fungal infections. So another fungus, right? Ringworm is a fungus, and we are seeing increases in resistance to regular old ringworm infection. Trichophidin, epidermophyton, microsporum infections are starting to show some pretty nasty resistance. Just common ringworm infections. Marburg. This happened decades ago in a place called Marburg. It's very Ebola-like. It's bat-oriented, but you can also get it through human body fluid and blood, much like Ebola is transmitted. So Marburg virus is something that is being emerged in the last year and a half, and that's kind of an ongoing thing to follow. Again, not much treatment for Marburg. This is like Ebola, although we've gotten a little better with Ebola with treatment and some vaccination help. Marburg still kills up to 88-90% of its victims, so a really scary disease. Just talked about this recently. This is infectioncontrol.tips. Was very excited to write this with one of my alumni, Priya Digat, who helped lead author this. She's an infection preventionist now in Philadelphia. I'm sorry, in New York. She went to school in Philadelphia. And she's in a hospital and a lead infection preventionist. And so she's always doing infection preventionist type of work, but loves to write and talk about these types of pathogens. And so super proud of her. She's been out about 10 years now doing this type of work. And Crimean Congo hemorrhagic fever, CCHF, transmitted by ticks. And so again, this is a disease that can be very zoonotic in nature, and it can be eventually can lead to death, but it also leads to a lot of morbidity and other issues. And so this is one to keep an eye on as well. Again, vector-borne diseases are something that I'm always keeping an eye on, because ticks, mosquitoes, flies, other things can transmit these in ways we don't think about. Certainly want to keep our eye on influenza, including avian influenza. I would encourage you to check out some of the articles that we've written in ASM. They have a bugs and drugs component in their online presence, and I love writing about the historical aspects of different pathogens. Dr. Andrea Prinzi and I put this together. About to release and publish one on malaria with respect to not only historically how it's going on, but what's happening currently in the US. So that should be, I think, an interesting read for you guys to check out. Just, there is so much history. If you're kind of into history, whether it's just normal history, but looking at history through the lens of infectious diseases is really interesting. If you are a public health or medical laboratory, or even, on the other side of healthcare, physicians and things like that, it really is phenomenal when you look at what's happening with malaria or yellow fever or other types of things. When you go backwards in time and then shoot forward to now, you're seeing some things that, we should have learned about. This has been a really kind of scary thing, right? Some of you've seen this fungal meningitis outbreak. It's basically up to a little over 200 people now in the United States that went to have either implants or liposuction, and they underwent epidural anesthesia. And so Fusarium solani is the culprit, and it is being found directly in cerebral spinal fluid. And basically it's a killer, because once it gets in the CSF and gets to the brain, you have major issues, obviously, to treat that. Full meningitis. And so this is a really sad story. There's ongoing issues with measles. There's actually lab advisories for people who are traveling now to be thinking about measles, because Again, measles is not something everybody sees anymore, but we are unfortunately seeing it reemerge. Really frustrating. Vaccination rates are really down for MMR, measles, mumps, rubella. So we're seeing a reemergence of measles across the world, including in the United States. This is right on the cusp of things happening right now. We've had 6 malaria cases in Florida in Sarasota County. We've had 1 in Texas, in Cameron County, which is down near the Gulf of Mexico. And then recently, August 18th, so last week, we had 1 pop up in Maryland, of all places. All of these have no travel history. So these are locally acquired. Again, there's a whole history about the U.S. back in history had, endemic malaria. And so again, when you think about the changing vectors and the changing weather patterns and the changing things going on with the climate, we're probably going to see more and more emergence of vector-borne diseases throughout the U.S. So again, just, we've been spoiled a little bit in the United States with respect to some of these, but we might have to start dealing with them, not just from a public health preventive and control standpoint, but even our world in the laboratory. Maybe we start seeing more of this now. Maybe we need to have it on our radar. Physicians need to be aware of it. Are we seeing something and think it's, influenza or something, and it's actually, malaria that can mimic different types of viral infections with fevers and headaches and other issues? That's a little troubling, seeing malaria pop up. And then yellow fever, and I kind of stopped here, but dengue, which is another mosquito-borne virus, chikungunya, Zika, all of these mosquito-borne viruses we're seeing some explosions, especially in Africa, 34 countries in Africa, 13 countries in Central and South America are continuing to be endemic. And they're also exploding in some of these places. Fortunately, yellow fever has a vaccine that's pretty effective. I got this back when I worked at the Department of Health, along with other vaccines that you don't get every day. But, something that I always remind people, if you're traveling, especially if you're traveling to other places in the world, you should really talk to your physician, your international travel component, about what you might need, whether it is a drug, like an anti-malarial drug, or an actual vaccine. So you want to think about that months before you travel. It could protect you against something you don't want to deal with. As we wrap up here, the WHO is a great place to check out kind of updates as well as CDC. So there's the potential for pathogens we know is very large, but the resources always tend to be limited. So we hope that continues to change. We're really focusing on these. WHO has an R&D blueprint where they show a list of diseases and pathogens. If you're curious what those are, they're right here. So those are the priority diseases, from COVID all the way down to disease X. Disease X represents kind of that international epidemic that we don't know about, a novel agent. And so we're always trying to prepare for some of that. Keep that in mind when you think about funding and research and how you prepare by practicing for these types of events. It's not cheap, but it's important to keep that on our radar. It's easy to quit funding and to quit thinking about this, but I always try to remind friends and colleagues that agents of infectious disease have killed more people than all wars and terrorists together. Why not fund research and control and protection for infectious agents? They're everyone's enemy, right? And they're notorious and they never stop coming. We have not found a way to stop dealing with them. The other lesson that I like to kind of share when I do talks about this is this idea of really working together to keep accurate science communication and global public health equity high. Misinformation is probably responsible for mortality at this point around the world. It's really unfortunate. It's really frustrating. I get angry about it all the time. And I try to combat it, as well as many of other people around the country and the world. We all have a part to play in this. A little bit of a soapbox here. But it's really critical. It's become part of our duty, I think, as healthcare professionals to try to share the most accurate information based on science and repetition and reproducibility, not just the latest, greatest headline grabber, right? That can be very dangerous. My references and resources, there are many that I've used. Feel free to check those out. Again, primarily working with WHO and CDC, but also a lot of research publications in there to check out. And I will stop here, and I am so thankful for this opportunity with today's clinical lab. I hope you enjoyed it, and I hope you have an opportunity to check some of that out and stay on top of it. So have a great day, and I will entertain questions or thoughts now.
Okay, great. Thanks so much, Rodney, for a wonderful presentation. So at this point, we are about ready to move into our Q&A session with the audience. A reminder, if you joined us late, you can submit your questions and comments by typing them into the Q&A box on the right-hand side of your screen. Another reminder, this presentation is being recorded. If you missed part of it or want to watch it again, we will make this video available for free on-demand viewing. Today's Clinical Lab will email you once that video is available within the next few days. So just stay tuned to your email inbox for information on that. And one more reminder, please visit the handouts tab on the right-hand side of your screen for supporting information about this event. So Rodney, thanks again. We have a bunch of questions and we have a bit of time to go through them. So just let me know how you're doing on time. But let's start with number one up at the top here. Can you discuss the factors associated with the globalization of infectious diseases, including historical and current examples of how select pathogens can evade antimicrobial treatments and how this confers an evolutionary advantage to that pathogen?
Yeah, that looks like a great essay question for one of my tests, right? Good question. And really, this kind of taps back into that early slide that I had. I have done, and you can find it on my YouTube channel, a full presentation on globalization of infectious diseases that walks through specific examples. There are so many of them, it's hard to talk about all of them. But when you go back in time, especially when you think about some of the pathogens that are treated with antimicrobial agents like antibiotics, most people understand that what we've created now is kind of a bottleneck issue. And so the overuse, the misuse of antibiotics, whether it's through our own issues of taking antibiotics when we don't need them, or whether it's through agricultural use where we don't need to be using as much in the food supply, and so forth. There's just so many issues around that. When we do that, and again, I know I'm preaching to the choir here, but when we do that, basically you kill off, a certain percentage of the vulnerable population of pathogens. Maybe you kill off 90-95% of them, but what you're doing is you're creating selective pressure, selective environmental pressure. So there might be, a percentage, 1 to 5% within a population that don't get killed because you don't effectively take that drug long enough, or you're using the wrong drug or something like that. And eventually that becomes the dominant population. So now all of a sudden we have a multi-drug resistant staph or something like that. The other issue is that these bugs, especially these bacterial issues with antibiotics, are very diabolical again, right? They can use horizontal transfer of genes through their pili. They can use other routes of transferring gene resistance. So it's not a long-term thing. They can literally use pili to touch each other and share that plasmid resistance gene with a different genus. So staph can share methicillin resistance to enterococcus. When you have patients in the same room, or you have something going on in a healthcare community where they're not quarantined. And it's very easy, I think we all know, that you have commingling of different resistance in organisms, in healthcare settings, in community settings. And so that starts conferring that advantage to those pathogens. It's not an easy problem to handle. It's a very complex issue. One of the things we can all do is to really work with our antimicrobial teams, our stewardship teams. Many of these are in hospitals and public health now, to try to get on board with the ID pharmacists, with ID physicians, with laboratorians, with nurses, Don't forget the infection preventionists as well as the environmental services people that clean, the custodians of healthcare, to try to start limiting some of these AMR issues. It's an all hands on deck type of problem for sure.
Okay, great, thanks. Let's move down. Let's go to number 6 on this list here. Were the death rates you showed specific to COVID-19 or in general?
Those are very, it depends on that question. So there was a really good link in that particular slide that took you to, I'd really recommend you check it out. It really has every country listed CFR and mortality rate. And it's all over the board. So if you look at it, in some countries it's lower, in some countries it's higher, but it is, to my knowledge, primarily the COVID-19. When you start disaggregating the data, some countries have started looking at, what was the mortality rate when you think about individuals that had diabetes, or what about people who had lung disease, for example, and you start seeing those variations within the data. So those were generalized with respect to each country, but it is related to COVID-19.
Okay, great, thanks. Let's go to question 7 here. Has the SARS-CoV-2 vaccines or boosters now been tested for prevention of spreading to others?
Yeah, thank you, Tiffany, for that question. That's a good question. One of the things we still are working on is when you get that vaccine or booster for COVID-2 specifically, is it truly stopping the transmission of it? Because what we know, and not all, and again, this is not true of all vaccines. Some vaccines still allow viral shed, and so people will still get the disease. The goal is ultimately to have, a good level of herd immunity to try to limit that. I do not think there's been specific broad clinical trials or other types of tests that I'm aware of that's looking at that spread, that transmission from primary infected people that were vaccinated. Hopefully that's coming. Perhaps they're out there and I'm not aware of it, but I do not believe that has been specifically done in a broad or generalized population type of study. So again, I still think it's critically important for as many people as possible to be vaccinated, just like we try to do for influenza. I mean, at this point, SARS-CoV-2 is endemic. It's probably going to be around for a long time. So we're going to really need to think about SARS-CoV-2 just like we do flu, like we do RSV, and some of the other things we deal with annually. And again, it's an RNA virus, so it's going to be difficult to find a universal vaccine that lasts for 5 years or 10 years. It's probably going to be an ongoing evolution of vaccines alongside the virus.
Okay, great, thanks. We have time for a few more questions here. This one says, how prepared do you think we are for a Candida auris pandemic?
Yeah, I mean, I think we're better off than we were 10 years ago, just in general, because of the immediacy of the lessons hopefully we've learned. I still think, I still think we're learning some lessons, but the big lessons I think that will help us going forward, really from all fronts. So this is a big question, right? Even laboratory lessons about supply chains and things that we need. So I think we've learned lessons. I know when I talk to my colleagues and my alumni, we've learned that we can't lock into, this is a very specific lesson, we can't lock into contracts, a 3-year contract with one supplier for reagents or a piece of equipment or a particular item you need for Candida auris testing. I mean, that's a problem. You need to think, you need to think multiplex. Do you need several suppliers so that if something happens to that supply chain, you can still get things? That's a big thing. I think we need to think about a national testing strategy. There's a couple of books I've read recently that really look at the CDC. I was at the CDC. My heart broke when I saw some of the, the hammering going on with that. That's a long answer because it's been underfunded. There's all sorts of issues that hopefully we've started correcting now. But the national testing strategy, CDC was never built to ramp up to millions of tests in a month. that is a difficult job, especially with a novel agent like SARS-CoV-2 was. So what I hope we've learned is that going forward, and I think we learned it a little bit and we saw it with Mpox, was that if we have the ability at the national level to understand what's happening and we get a test in a relatively decent amount of time that's working, let's get that thing rolled out to commercial labs as well as healthcare as quickly as possible, because you can't fight an unknown enemy and you don't know where it's advancing, right? So you have to kind of look at infectious agents almost like a battlefront. And if you don't know where the enemy is in the community, it's difficult to fight. And so I think national testing strategy is definitely better for something like Candida auris. Again, it depends on the agent. We know a lot about Candida. We know how to detect it. We have certain drugs that are still effective against it. We don't have a vaccine, but we do have some treatment regimens, and we know prevention measures. So I do think that when you know the agent, you're definitely better off. When it's novel, when it's brand new, that's a little tougher to deal with, and that takes a little bit of patience. But again, Operation Warp Speed, some of the things we did at the beginning of COVID were really effective. We knocked down some red tape. We still did the safety testing and things like that. mRNA vaccines and some of the antiviral, pushing through the FDA, pushing through the, what might have taken 5 to 7 years. We did that in like 18 months. I mean, I never thought in my life I would see that type of turnaround for a treatment option. So that's exciting going forward. And so hopefully those types of lessons will be learned. Hopefully we will grow. So here's my soapbox for you guys. We need to grow public health and medical laboratory professionals so that we have, a pipeline, and so that we have the expertise of some of my mentors to train even me, and for me to train future students and new graduates. Because 30 years ago, when I started in this field in public health, I was surrounded by all types of people, and I saw that shrink, and it's really hurt us, both in the public health realm and in healthcare. We've got to figure that out. We have got to find a way to support scholarships. We've got to find a way to support pay. We've got to find a way to support flexible schedules and to bring the brightest, most talented people into our field, because again, infectious agents are not going away. They're only getting stronger each and every year.
Okay, great. Thanks. We've run over our time. Maybe let's do like 1 or 2 more questions. So, feel free to let me know which ones you want to do. Maybe we could do number 9 here. In your opinion, why do you think it's taken us so long to come up with an RSV vaccine?
Yeah, good question. Hi, Melissa. Melissa is one of my alumni, so it's great to hear from you. Super proud of you. So RSV, respiratory syncytial virus, has been around a long time. I'm not super knowledgeable about all of the vaccination history with RSV. I do know we have gotten close several times with trials, and they didn't show the efficacy that we needed. Some viruses as well, and viruses especially. So I'm really a virologist at heart. Viruses are just difficult because of their ability to change and mutate so much. It really depends on the stability of the virus. DNA viruses tend to be more generally, I'm generalizing here, DNA vaccines tend to work a little bit better for DNA viruses rather, because they're a little more stable. When you get into those RNA viruses, it's kind of a crapshoot, more or less. I mean, it's really difficult when we see something like influenza. We see something like COVID, SARS-CoV-2, even Ebola. These different RNA viruses just have such a propensity to mutate at high rates that it's almost impossible to create a vaccine that's going to last more than a short term. And so I think this gets into pharmaceutical development. I think it gets into the kind of funding you're going to pour into something that may only last for 2 years. Again, so sometimes, and this is Rodney speaking, kind of my opinion on this is that sometimes I think we need to look at a way to have almost a subsidized public health funding opportunity so that you have kind of ongoing R&D around some of these agents. It's going to be really hard even for a a pharmaceutical company to tie their whole business model around, an infectious agent vaccine, because there may not be a lot of money in it if it doesn't work for a long term. So a difficult question to answer, but I think those are some of the factors of some of these viruses and why it takes so long to get a vaccine.
Okay, great, thanks. We have time for one more question. I don't know if you'd like to look at the remaining questions and pick one, or if you'd like me to pick one.
Oh, let's see. Let's go with number 11 there. This kind of goes back into antibiotics. Is there a possibility of discovering highly effective antibiotics in the future? And if so, what avenues of research or developments might contribute to this? I think we're seeing some of this. There has been some recent development of really effective antibiotics. Again, many factors tied to this. So we've already talked about funding and looking at different types of research avenues for antibiotic types of agents. The other piece around this is the prevention of infections. And, so we're really starting to look at, we can't just totally rely on rolling out antibiotic after antibiotic after antibiotic. That's definitely something we need to be doing, is looking at R&D and developing new antibiotics. But we know that if we don't take care of the prevention of infections and we don't take care of the judicious stewardship of said antibiotics, then they're going to become less and less effective over time. So I think there's a balance there. Again, I'm going to really promote here the idea of looking into antimicrobial stewardship teams in your facilities and becoming part of that answer to more effectively educate physicians and lab workers and nurses and the public about how dangerous AMR is becoming and how there may not be a new drug 5 years from now. And we really need to save the ones we have. And the best way to do that is to be more careful with how we treat infections. All of us play a part in identifying the correct microbe and then finding the best susceptibility test available to get the right gun for the right enemy, so that we're not using a shotgun, we're using a rifle to kill that bug. That helps prevent AMR when we all are part of that. It's really easy on a day-to-day basis to kind of forget about that, but every time we all kind of support that effort, we are helping with the idea of antibiotics being more effective in the future. So again, kind of a big answer there, but it's a complex answer.
Okay, great. Thanks very much. Unfortunately, we have run out of time at this point, so I think we're going to have to cut the questions. If you'd like, we could forward you the remaining questions if you'd like to get back to people offline, if possible. But Dr. Rohde has helpfully provided his contact information on the screen in front of you, so if you'd like to reach out offline, that's how to do so. But that does bring us to the end of our webinar. So again, just a reminder, this webinar will be available on demand shortly following this live presentation. Please watch your email for a message from today's clinical lab, and we will alert you when that video is available. On behalf of today's clinical lab, I'd like to thank Dr. Rodney Rohde for all of the hard work he put into this presentation, and I'd like to thank all of you for taking time out of your busy schedules to join us. Once again, thank you to our sponsor, the Joint Commission. Their support allows today's clinical lab to offer these webinars free of charge to our readers. Please tune in for our next webinar at 12:30 p.m. Eastern, preparing MLT and MLS graduates for transfusion practices. For more expert insights into the latest tools and technologies for the clinical laboratory, please visit our website at clinicallab.com. We hope you can join us again. Thank you to all of you for being part of the Today's Clinical Lab Digital Forum, and we hope you have a great day.